Good afternoon, everybody. Thank you for joining us on our webinar today. It's the first one that I've been able to participate in, which I'm very excited about. Our presentation is a collaboration from TexLa Telehealth Resource Center and the Society of Critical Care Medicine SCCM Surgery Section. We're excited to welcome Olena Svetlov, and she'll be presenting on the applications of telehealth in the treatment of delirium in ICU patients, including ethical concerns related to our topic. We have reserved some time at the conclusion of her presentations for questions and discussions, and have a few introduction and housekeeping slides before we jump into the presentation. If you have questions, you can either put them in the chat or save them for the end, and we'll go over them at the end. I'm going to go through the housekeeping slide stuff with Ms. Zoya here, and we'll go from there. Thank you very much.
This educational activity is a project of TexLa Telehealth Resource Center, a federally funded program with F. Murray Hall Rural and Community Health at TTU HSC in Wellhead, Louisiana, with generous support from Health Resources and Services Administration for HRSA. CME Ethics credit is available for participants of this webinar, and a link to take the survey will be provided at the end of this presentation, as well as emailed to the attendees. These are just some helpful tips for our webinar and for ensuring you can receive CME credit if so desired. Please make sure everyone is muted, and please type any questions or comments you may have during the presentation in the chat box. Dr. Lee will now introduce our esteemed speaker. Thank you.
Dr. Lee, by the way, is the head of our Patient Safety Committee. So Dr. John Lee, take it away.
Thanks, Ariel. Good afternoon, everyone. Dr. Olena Svetlov is a critical care clinical nurse specialist at Kaiser Permanente Los Angeles Medical Center. She obtained a Bachelor of Science in Nursing from California State University, Northridge, California, and went on to complete a Master of Science in Nursing at Azusa Pacific University in California. She subsequently obtained Doctor of Nursing practice at Grand Canyon University in Arizona. She also has Bachelor of Arts in Slavic Languages and World Literature from Zatomir State University in Ukraine. She worked as an advanced practice nurse at Cedars-Sinai Medical Center in LA from 2016 to 2023. She provided daily clinical support to nursing staff, as well as providers with surgical, transplant, and trauma ICU patients. She currently provides clinical guidance at Kaiser Permanente Los Angeles Medical Center. She also provides cardiac education to nursing staff. She performs quality improvement projects and clinical research. She is a member of the Society of Critical Care Medicine. She is the president of the San Fernando Valley chapter of American Association of Critical Care Nurses. She has multiple national presentations. She has many volunteer experiences, but I think the most notable one is Stop the Bleed training for Ukrainian citizens and military. She also has received many honors and awards, including Volunteer of the Year Award and Zifkin Family Nurse of the Year Award from Cedars-Sinai Medical Center. We are extremely honored to have Dr. Svetlov speak to us today. Olena?
Good afternoon. Such an important introduction, making me blushing. I didn't even know that I'm going to sound that official. So it's an esteemed honor to be with you today and talk about our beloved delirium. And the geriatrics is something dear and near to my heart because I grew up with my grandparents. And this is something that I'm really passionate about it. So let's see if I can share the slides and we can have a fun conversation. All right, let's go ahead and start. My apologies for a little bit of a delay. Technicality, it's always an issue, right? Well, first of all, look at this beautiful slide. This is if you ever have a chance to come to California. It's right behind Zuma Beach. It's El Matador Beach. And this is a beautiful place you can come and enjoy and have a beautiful time in California. Also, as a speaker, I would like to acknowledge you that I am a nurse, and I'm very proud to be a nurse. I'm a doctorally prepared nurse. And I'm a proud ambassador of Nurses Improving Care for Older Adults. So this is what NICH stands for, and I'm a strong advocate for the older adults. Thank you. Next slide. And, I was already presented, but something was not shared with you that I do volunteer as a singer. I didn't know that I have that talent. But ever since the conflict in Ukraine happened, I auditioned for singing opera and recently we presented together with a Korean orchestra, and we sang opera piece for concert for peace in the Walt Disney Concert Hall. So this is something that the talent I didn't know what I have, but I guess all of us have some kind of interesting talents. And of course, I'm going to mention about my husband that I'm very proud that he is my supporter for all these years. And I'm a proud of mom, 3 kids. And I have a teenager, 17 and a half. I have a dog and a cat. And my teenager is fond of 5 fish tanks. So I don't know how I'm going to handle it, but this is what we're doing it. Next slide. Something official that we have to go in order to get the CEs. We're going to go over learning objectives. We're going to jump in on the impact of delirium in patient outcomes. We're going to identify the benefits and limitations of the screening tools that currently we do have in ICU, and many of you are aware of. So we're going to go over them. We'll look at the possibility of a non-pharmacological agents that we can help us to prevent delirium. And we're going to go over a little bit of a pharmacological agents that we present here, and that's how it's working in intensive care. We will go over some ethics and ethical consideration caring for older adults with delirium and how we can handle this difficult situation. And definitely, we're going to explore the telemedicine in preventing and managing delirium in ICU. And specifically, I'm going to show what we do here at the Kaiser LMC. Disclosures, I don't have any disclosures, and I'm going to just jump in. Well, everybody is aware that the author of Delirium Awareness Campaign was Sharon and I. You know, she's our champion for all the literature that started. She started as a resident. Zoe, that goes to you. So if you have any patient, you know, something passion that you are really, really care for, you know, Sharon and I, this is a person to go by. She was really interested in what's been happening with her dad, and this is how delirium started really getting attention. You know, she's a strong researcher, and nowadays she's our leader in the research medicine for delirium. Thank you. Next slide. And a very, very important person in our world for delirium with the Society of Critical Care Medicine from Vanderbilt University, you know, Wesley Eli. He's a pioneer, and he's like a champion for all the delirium efforts that we have here in the United States. Till 2018, basically the whole work was pretty much in every single institution across the United States. Then we see the research went all the way to Canada, and now we see more and more an article coming from the European countries. They're getting attention to the delirium. So that's really a huge appreciation to Dr. Wesley Eli. He came out with a couple of very important books that I would like to share with the audience: Delirium Critical Care, Way Early, and just a recent publication with Acute Brain Dysfunction in Critical Ill, where he does define delirium with all the spectrums and where we can find the best solutions to treat and prevent delirium and older patient population in critical care. Thank you. Next slide. Yeah. At the same time, in the journal, I believe it was in 2017, Delirium in Hospitalized Older Adults was published, and it was kind of like paying attention in the global market with Dr. Marcantonio. He presented with a case presentation on the older adults and what's happening with a person who is just coming in for the major abdominal surgery, and just, you know, regular abdominal surgery, not much of issues with there, but he is studying from the forgetfulness, and he went on with this article how forgetfulness led to the sequence of the events, and as a team, what we need to look at the older adults being in ICU. So that was a very interesting article. So if you have some time, please go ahead and take a look at it. It's really out there and really outlining what we need to do in ICU. Next slide. With the Society of Critical Care campaign, we have our guidelines, PADIS guidelines 2013, newest one 2018, where we added a new element to the ABCDE bundle. We came up with the ICU Liberation campaign, and the F, the letter F, is really significant for family engagement. If in the European country, we don't really see family involvement in intensive care, we separate the patient, and the family is not allowed to come to visit the patient in ICU. We see in Europe that now more and more families are allowed to come. For us in the United States, we do know that family comes, and patient is not actually the one that we care for. We care for the family. And the moment the patient comes to ICU, the recommendations are to have a very good discussion in the very beginning, like what the goals of care in ICU. We're attendings, we're CNS of the unit, and nurse practitioner and multidisciplinary team meet with the family, discussing what we need to do. So with this very, very profound work with the ICU Liberation Campaign, we're trying to go across the globe. And I know our team of amazing doctors currently in Ukraine and teaching our physicians back home in Ukraine on how to prevent delirium in the warriors, how to prevent delirium in the people who were wounded because of the bombing and shelling is going on. So thank you so much, Society of Care, of doing this. Thank you. Next slide. Yeah. I think I have a slide before that. So a couple, yes. So delirium occurs in many populations that you know. At first, we thinking that delirium is older adults and let's take care of it. But actually, delirium is something that all of us have. For example, just remember yourself, like when you travel somewhere and you wake up in the hotel, like you, I know some of you were in ACS in Boston. You know, the first night you're like, you know, there, you flew in 6 hours, 7 hours or whatnot. You're waking up and you're like, okay, hold on. Where am I? What is this? What time is it? So this is what's happening with us in the healthy population. This is exactly the state of delirium. We're trying to reorient ourselves to the area where we are. Now, if it's a patient that comes in the hospital, it's a known environment, plus it's induction of the agents, pharmacological agents that really altering our chemical balance and altering our perception of reality. So patients by themselves, they cannot really easily go out of that state of delirium and reorient themselves. That's why we're asking our nurses by the bedside, guys, making sure you orient your patient and let them know where they are. Help them to have that process built up. It is common for older person in the hospital settings because it's a known environment. And it's really, you know, documented in the literature. We do know the risk of the population is post-operative, all critical cares, and we have a stroke units, ER, because of a lot of the noises, unfamiliar environments, the agents that we give and we administer to the patients, but also in pediatrics. Pediatrics can have a delirium as well. So all spectrum of a human life can be affected with delirium. And this is something that we need to understand. Like as a healthy adult, you remember yourself traveling to a different country. On the first night, you're trying to orient yourself. This is a state of delirium. You are capable of doing it. When the patient's in the hospital, they cannot do it themselves. That's why it has to be a system in place for every institution where we can help the adults to overcome and get better and get out of this delirium. Next slide. We do have in the literature document two types of delirium. That something very, very important and everybody knows and every kind of like is scared in a way. It's hyperactive delirium. It's very prominent, you know, patients agitated, trying to get the tube out, not following commands. And it's most recognized in every assessment. You know, in our residents, when they're coming around and they're doing pre-rounds on the patient and they're trying to see what it is. Oh, he's delirious. Oh, he has dementia. Oh, he has some downing. So all of this terminology coming in and which is incorrect. So in the clinical practice, we should really have something in place that really differentiates between all of them. So hyperactive is very famous, right? What about the hypoactive delirium? And we can have a mixed delirium as well. We have a hypoactive, it's less recognized with patients because they're sleepy, they're not that arousable, you know, they are on sedation. So people think, oh, they're sleeping, don't bother them, they sleep, because when they wake up, oh boy, what's happening? So we have to have our conversation with residents and nurses on the floor that we do need to wake them up. We need to get them out. I want to share the story that the other day I was rounding on a patient who had a delirium, and we were able to battle that delirium. He is out. And I was asking him, how's his perception? What did he see and how he, you know, perceived us? And he said that while he was in ICU, he knew that he's in the hospital. But it was so scary for him in an environment, he thought that he's in a dream. And because it's a lot of noises of the chest tubes and the alarms and all the unfamiliar noises, he thought to himself that he is in a bad dream and he need to wake up and go in a different state. So he didn't realize that reality, that we were there with all the noises and trying to wake him up. We were a true reality. He was so scared that he was trying to go to his the other reality on his dream or whatnot. But that's interesting perception. And later in the slide, I'm going to show you how our patients perceive delirium, what we can share. So one of the slides of the ICU Liberation campaign, the teaching slide that we use in our settings, we used it at Cedars-Sinai, we're using it here at Kaiser. It just, the slides of what people see in a delirium. That's not what we see in the reality. And they might have hallucinations. They might have audible hallucination, delusions. They might have the objects in a different form. They not only like can see like a nurse walking in the room or providers see in the room or humans be in the room. They might be see different colors. Emotional disturbances might be feel scared. And that's why we see the agitation there in ICU. And they might not be able to fall asleep. So that's something that in the tools we do assess for the sleep and quality of sleep on these patients. Next slide. I see it's right there. Next slide. Yeah. And this is the that's good. So reaction to the patient delirium is from ethical standpoint. You know, many physicians, they were not trained on delirium. And honestly, with all my accolades of the nursing school, we never really studied delirium. It was just basically kind of like mentioned, and it was mentioned in terms of sound downing of the patient, and was not really teaching nurses or teaching what can we do in order to avoid delirium in the patient population. So we're just feeling frustrated, you know, and I have an experience of that, of like, oh my gosh, what I'm going to do with this patient, how much sedation I can give it to him so they can finally give it calm down, because with my assignments 1 to 2, it's kind of busy. So that's something that I start working with my nurse and explaining this from my personal experience, from a literature perspective, that we have to really look at the patient as a whole, because they are in a state of delirium. It's not just being mean patient to us. And with the family. So what we do with the family when we have meetings with them, we're trying to explain to them that, guys, this is not, the patient is agitated with you. It's not because they don't love you. They are here, they're here for you, and they love you. They're the part of a family. So something that was interesting, I shared with my nursing students and the residents in Cedars-Sinai when I was there doing my project. I shared with the residents, this is what patients see. One of the famous artists here in the United States, Zakatis 2018, this is his perception of delirium. He's a famous artist. He started out with walls in New York and on the street painting and whatnot, and now it's like very expensive paintings. But this is what he saw when he was in the hospital. Let's look at these colors, right? There's no figure of a doctor, no figure of a nurse over there. There's no family there, just, you know, spectrum of light, right? So that's something that they see. Next slide. I think it's going to be more visible for us. Another artist, I believe it's next slide. Yeah, another artist by Christopher. Okay, see it being recorded by Christopher Gabor. Look at that. This is how he see the doctors and nurses coming into the room. Something that we know, and then in our webinar we do talk about like perception of you. If you're taking too much medication, you see the spiders, you see the crawling, this and that. This is what he saw. And then, you know, he's going to be scared because he saw everything in the forest and everything in the unknown. And then there's something like a bear coming out of the room, right? So this is very scary for them. No wonder they're going to be agitated. So this is a patient's perspective. And interesting, like about a year ago in Los Angeles, the next slide, in Los Angeles, we have a immersion into the art of Van Gogh. And Van Gogh is very famous an artist because he was drawing everything in the different colors. But the most prominent colors in his art, it was like yellow and blue. So now the providers, you know, we do know yellow is like, you know, a sign of depressions, and the blue kind of like goes with the blue, like being the blue. So that's the melancholy. That's the colors of disturbance. It's the colors of an unstable state. So was he in a delirium because he was, taking a lot of alcohol when he was making his paintings and whatnot? So we do have delirium. It's very well documented in art. And for us as a providers, as caring providers together, we have to understand this patient's perception is different than what we know. So this is something that we want to share with you. It is there in the art, and it's now. Let's go jump into the art of us. Next slide. So at Cedars-Sinai, I was there from 2015 to 2023. In 2016, I was invited to be a surgical clinical nurse specialist. And it's 24-bed, very, very great team. We've been doing like liver transplant, trauma, pancreas transplant, kidney transplants. It's a busy floor, different patient population. We're magnet institution, tertiary centers. It's a lot of research, a lot of studies we're doing. And they're very supportive into the articles and the publishing work together. So as a team, we're actually looking at the patient population, next slide, looking at the patient population, trying to see why we have an increased length of stay. What can we do in our ICU to get these patients out of ICU? Things like we're pretty much, rounding on the patient. We're pretty much doing multidisciplinary rounds on them, but patients, stayed in ICU and being agitated. So the team of our amazing nurses who are now our nurse practitioners, Brian Casimir, he is a critical care surgery nurse practitioner at Mount Sinai Hospital in New York. We have Toby Muniz, he was our fellow, and Dr. Anar Silets, she was our fellow as well. So they were in the rotations at Cedar Sinai, and now Dr. Silets is in UC, she's attending there. And Tobias Muniz, he's attending trauma surgeon in Santa Clara, here in Northern California. So it's really proud to show the work of Dr. Lay, who's been at Cedars forever. He's an amazing surgeon, amazing researcher, and he supported my nursing team in work on the delirium and the surgical trauma transplant ICU at Cedars Sinai. Dr. Greina was our leader at the critical care, and he was my mentor from the nursing side to support this project. And it's all accolades to Dr. Lay because he really allowed us to work together, create the environment for the research, and make it better. And we will show what we did in ICU. Next slide. We used our CAM ICU's tool for screening delirium for every single patient, and our nurses were documenting it. So when we're working with the nurses, kind of like assessing them, we just realized that at certain occasions, nurses were just documenting, not really performing, because not every patient population can actually use this tool. Because if you're a trauma patient, frontal cortex is really affected, can you really ask them a question to follow you? They cannot. Some patients with the liver cirrhosis, waiting for the liver transplant, can we really use the CAM ICU for them? So it was not really usable. That tool was not really usable. However, nurses in the assessment were telling me, Olena, but we do see the disturbances in sleep. We do see sometimes they follow, sometimes they're not. So then they pushed me into the work with the team and looking with the Society of Care Medicine if there's something else is available. So I reached out to Society of Critical Medicine, and I got permission to use another tool that is available for the patient who cannot fit into the CAM ICU, which is ICS. It's the next slide. Yeah, it says it's a tool that allows nurses, providers. Actually, you don't really need to be specifically certified for anything. It's called Intensive Care Delirium Screening Checklist. Basically, it goes with your assessment, and you can tell and you can score up to 8, and you can score up to 4 if your patient has delirium or whatnot, if you're positive or whatnot. Like patient quality of sleep, if you have any hallucination, disorientation, the following your commands or whatnot. So that's kind of that's my basic assessment from a nurse. It's your basic assessment as a doctor rounding in a patient. So you already know, okay, my patient has a delirium. So that tool, we start implementing and using it in terms of identifying if my patient is positive for delirium or whatnot. So that was our know-how in a way for the surgical trauma unit, and it really works. So I want to show you what we actually did. So next slide. So we'll look at the patient population and trying to see if the implementation of, instead of doing the CAM ICU, if implementation of this tool will really help us with working to the length of stay. Because if you use the right tool, then I can alert my providers early. The nurse can alert providers early. Hey, this patient is high for delirium. They can alert the pharmacy. Maybe we can adjust some medications into the sedation principles or methodology of this patient. And what can we do better? So kind of bring team early on versus just having a CAM ICU positive, CAM ICU negative. If it was not really, tool was not really working with the patient that we have at that time. So next slide. So we have our population is mixed. So we have trauma, we have pancreas transplant, liver, kidney transplants. So it's like a mixed patient population. So we decided just to look as a population, all ICU patients, just to see, not differentiate with any of the population, just look at all of them in general. What can we do? And we run the project over 8 weeks. Next slide. That was a pick a question that was for this project. And we'll look at our ICU to see the length of stay. And the length of stay depends on the patient population varies somewhere about like close to 7 days, close to 13 days, and like outliers on this bell curve, right? But basically the length of stay, for all this patient population was about like 12 days. So it was like kind of like really hurting our unit, and we'll try to see what we can do better. Financial impact is huge because depends on the patient needs. The patient could stay there for a week or longer, right? And then how much resources goes to the room. So the cost varied from $5,000 per day till $11,000 per day. And Vasilevskis, in his study in 2018, he basically said that it can round all the way to $18,000 a day. It depends what's going on with the patient at that point. So next slide. So we did have a literature review, but the way how we did it, so every Tuesday we have a journal club with Dr. Lee, making sure our fellows kind of like target the areas. And our fellows ask our residents, guys, go dive in, look at the literature, what is out there, what can we do better, what tool we can actually use. It's not just like intensive care delirium screening tool, maybe something else is now coming out. So what that tool you think will be applicable for our patient population. So we had a couple of sessions on delirium, on a tool discussions for a couple of weeks. And we're debating, like residents were presenting their articles and debating, is it like a good article, not good article? Can we go with the findings of this article or whatnot? So Dr. Lee really allowed to have this beautiful discussion among the residents, and I was, part of it, representing nursing. And we also invited geriatrics nurse practitioner Kathy Breda, who came from Mass General, I believe it's in Boston, Massachusetts. And she just brought in the geriatrics aspect into our patient population, and she shared her knowledge with us. So then we decided, okay, we're going to do the quality improvement project. We're going to get 90 patients, and we'll see if we can have pre-screening. That was about 42 patients. And after implementation, we followed up with this tool and our multidisciplinary rounds. It was a 48 patients post-implementation group. And we have these discussions after our quality improvement project and discuss the results after that. So length of stay was our dependent variable. Screening tool was an independent variable because, variety of that. Next slide. And this is the results that we had. I believe I showed next one. So from the non-pharmacological methods, nurse practitioners, geriatric nurse practitioners, clinical nurse specialists, education council from nursing were educated on the principles of delirium and how important it is. And we'll work with our COOL team, which is interventions team that help us build in EPIC what the nurse needs to do. Because doctors, you have your plan, you put the orders in, and nurses here to educate, and nurses here to execute and support the patient. But how can we make it more easier for the flow for everybody? So if you are, for example, like today and taking a lecture, or you are doing a surgery, what can we do as nurses right away? So that's already built it up for us. Each nurse has a delirium protocol built in, and when we know what to do as a nurse, notify my pharmacy. I have to reorient my patient. I make sure the family is visiting. I'm making calls to the family and to see who is coming to visit the patient, who can assist. Also going to reach out to volunteers who can come and sit down with the patient. Even they're intubated, but still we're going to talk to them and guide them through and kind of help them out and continue reorienting them. And for the nighttime, we made entire protocols in there for nighttime, making sure everything that we do in the units, put it all together. Try to put the meds together. If you're doing the bath, you try to do your bathing and dressings at the same time. Don't break it down, making sure it's all together. That's there, that it's there. And then something that we're working in Kaiser right now, but this is really helping because providers are focusing on one side. They can go do the surgery, they can do their research, analysis or whatnot. At the same time, nurses know what they're already doing. Next slide. From a pharmacological standpoint, we had Russell, who is really, this is something that we posted on each of the room, just kind of remind us what we need to do for geriatrics. And we did it in intensive care. We also did it in the medical surgical unit, and kind of like complete the focus of education at the same time as a reminder for nurses and providers and social worker, anybody who's in the room. This is what they need to do. We're going to walk our patients. We'll make sure the lights up during the day. We'll make sure lights down during the night. We'll make sure if patients wearing glasses or lenses at home, bring the glasses in. We have earring, like little pieces that we kind of like, decrease noise at night, so we can use that too. So, and mobility, we're mobilizing our patients. We're having our physical therapists, they're intubated or whatnot, we are getting them up. They are going to be up. So that's like RAS 0 is something, it was our battle with the whole team, because it's not something that the nurse would like to have and see. My intubated patient, RAS of 0, okay, go for it, right? So it was a lot of education and explaining to the nurses why it needs to be done and why it's so important for the patient. In the next slide, what we did, we worked with our pharmacists in terms of choosing agents for sedation. So before it was just Versed, Propofol, Versed. So Versed is huge trigger for delirium, right? So we had to work with our pharmacist during those journal clubs, and Dr. Lay was leading this. And we decided, okay, we're not doing Versed anymore. Instead, we're doing fentanyl. And instead, we're going to do fentanyl for sedation and for pain management at the same time. And we built up the program, like it's an EPIC, it's an order set. So for sedation, this is what we do. And for pain management, this is a pain scale. So that was something that we changed, and it really worked. And our team decided, okay, so we're going to be using 3 agents that for our really, extreme hyperactive delirium, if it's no other non-pharmacological agents are working. So this is all listed there. This is in the literature. And something else we had to really work on, restraints. So it's just a rule of thumb. Anytime you intubate the patient, nurses already applying the restraints. So there are different type of restraints. We discovered that we have a restraint that is kind of like partially restraining the patient. So they're going over their elbow. So it's just, restricting the mobility that much and creating a little bit like a cuddling effect in a way. So patient would feel a little bit, there's something heavy on their arms, and they keep it like it's like a blanket, so it stays in, versus just giving the wrist restraints right away and tie them up. So we saw in our units that every time when you use wrist restraints, patients will be more agitated and trying to get them out, versus if you have a partial restraints that just like, keep them in, keep the limbs straight, and working with them this way, it creating the comforting effect, and patients were not at risk of extubating themselves because they are really like limiting this ability. They wouldn't be able to bend and extubate. So we just try to do it, and then they, remember, and we orient them that, yeah, you extubated. This is very important too for your breathing and whatnot. So that was a lot of work was done as a team together from the pharmacy, residents, attendings, nurses, day shift nurses, night shift nurses, travelers, because as you see, the project was done, right after COVID, so it was still like a second pandemic, so it was a lot of work needed to be done on the unit. So it was definitely, team approach to battle this delirium, right? From a telemedicine standpoint, we didn't really use it at Kaiser, at Cedars-Sinai that time, but I'll show later what we start doing it at Kaiser in addition to. So next slide. Thank you. And this is our results. So there's like a statistical significance and there's a clinical significance. So when we actually hired a statistician to run the statistical analysis for us, we did an independent sample t-test because, there are different sample sizes. We cannot have like, same sample size, keep them on and see how it's working after, right? So it's different people. So that's why it's the t-test was used as independent sample size t-test was used, and we differentiate. Look at that p-value. So that really like team did not they didn't believe that this intervention will work. They're like, oh my gosh, look at our p-value. We're kind of like making a difference. And for our specific patient population at that time, we looked at, reduction in just short period of time. It decreased to 4.8 days. So I was like, okay, that's something interesting, right? And we'll look at the statistical significance and the clinical significance. In our critical care, we'll look pretty much, I mean, for research purposes, yes, we'll look at the statistical significance, but for us working by the bedside, what is my clinical significance? Do I bring the difference with my intervention to the floor? Yes, I do. Then it values. So clinical significance was a big deal for us, and we decided to continue this practice. And we are using two tools, CAM-ICU and the intensive care delirium screening checklist. We change our agents. It's fentanyl right now. Even when I left Cedars-Sinai, it's a fentanyl throughout. Versed is not used. It's like a standard of practice. And our restraints, we change the policy and procedures in the hospital where the first line of restraints, it's non-restrictive restraint. So it's like this partial restraint that we use. Next slide. Yeah, this is a slide you can really see, but we'll look at our patient population. I think I added some tables in there for the next slide. We'll see if I added there for pre-intervention age and after. No, I didn't. Okay, so for pre-intervention age and after, so the age predominantly we try to look at the patient population was geriatric patient population. So we did have male and female in our pre and post analysis, and the median age was like 58 years old to 60, 65-year-olds. So geriatrics and young older adults, kind of like in transitioning this way. So the adult patient population, and this is our change for the clinical significance that I told you about. 4 point something days was a big deal. That was a big deal for us. So these findings were shared for entire critical care. Cedars-Sinai Medical Center. It was shared on nurse practitioner symposium in Boston last year. And this is a practice that I brought into Kaiser LAMC, and we're about to implement that. Next slide. Let's see. For the telemedicine, we'll look at when I joined Kaiser Permanente, the first thing I walked in, I realized that they have a virtual hub. I'm like, okay, what is a virtual hub? And instead, thinking about it, how can I, work it with my ICU people? Do we have something for ICU? Can we have it here in implementation? And then starting looking at the literature. So the video consultations exist from 2020. It started there, right? So we see the telemedicine exists in Europe as well. It's not only in America is doing it. The Europe is doing it as well. Asia is doing this as well. We have it's highly, highlighted the impact of having this tool. Like at that time, remember 2020, we didn't have Teams, we didn't have Zooms. Webinar was just like evolving or whatnot, but we do have a very strong support of a devices that can us connect with the teams. If at first in the literature, next slide, if it's a first in the literature, we see that they're highlighting the importance of reaching out to people in suburban areas of unreachable rural areas of the patient population. But we see that there are more and more literature coming out in Europe and the United States that telemedicine really helping also battle and delirium here in ICU. So what can we do about it? We need to look and involve our tools here in the United States and work together as a team to battle the delirium with patient population. So recent articles I just listed for you. So it kind of like highlights it's not only America is doing it, it's like Europe and Asia doing it as well. So the whole globe getting into the perspective how important it is to battle delirium. And we do have tools to battle it. It's a tool for screenings, virtual visits, virtual orientations, right? So I think I have next slides over there where I'm sharing. So at Kaiser LAMC, it's also a tertiary institution. We're a teaching facility. We have 560 beds. We about have 200 plus residents over there. And the next slide. So what we do on the virtual hub, yes, and then telehealth improved nursing care. So yes, that's for both. It's not only for the provider standpoint. So for nursing care, guys, nurses came on board and be together, and we have to work together to battle delirium, right? So what I want to share with the Kaiser that they do. So we have a virtual hub where at night we have ICU coverage, ICU coverage where the physicians, and there are 3 nurses at a time. They covering ICU, I believe it's the next slide. They're covering 20-bed ICU here that we have mixed ICU, so just covered. So yeah, so right here, the physician sits right here at night. Nurse sits here. There's another one area here and one area on to the each of the angles, corners, and each nurse can see 8 patients. So Kaiser LMC virtually monitoring and participating in telemedicine for 20 ICU bed here, Kaiser LMC, and 40 beds in Ontario Kaiser. So it's in a distance coverage. It's not only nursing, observing, assessing, making recommendations. It's also physician is available at night, 100% for any consultation, order placement, assessment, and guidance of practice. So something, well, as a spirit of Halloween, so I just took the pictures over here. See, it's like if the green light, so it means it's not occupied, nothing is being observed, there's no patient information being shared. So it's a green light right there. Trying to make it ergonomically, as you see, there's like, you know, green plants there. It's just making sure it's nice and comfortable. But then in each territory, it says like a little stop sign. So on video call. So anytime anybody on the vision will see the red light, so if something is a video call going on, there are communications happening with the nurses like Ontario Kaiser from Kaiser LMC, and that's, you know, limited interaction should be in that. We shouldn't be interacting at that time because the doctors are there, nurses are there at the same time. So that's how assessment through the telemedicine is happening now. Next slide. I think I have a couple more slides in there. Yeah, so anybody who comes into the Kaiser LMC, we do have digital innovation as a telehealth is available. They see video calls to the patient ambulatory. Kaiser LMC is Kaiser is a system big on preventative medicine, so they're really investing into the telemedicine with the spectrum. But for us in ICU, with our surgical patients or whatnot, how we are battling the aspects of delirium assessment, we are using this device. We just implemented it. It's called Virtual Sitter. So it's in addition to the nursing assessment, the doctors can come and zoom in and really kind of like be there and give an advice what's happening over there. So is somebody there constantly monitoring you and can provide patients' need right away at the moment. So you do it right there. And also we're partnering with American College of Surgeons, and we're implementing early mobilization program for ICU patients and medical surgical patients. So we're trying to improve care post-operatively for all our patient population here at Kaiser. We launched it last week, and I'm just very proud to share that. So we're going to be getting to the 4M modality for geriatric patient populations and trying to get to the standards of American College of Surgeons. So that's something that we're exciting to share. And next slide, I believe I have, as a conclusion, what can I advise as a nurse to the team that we need to work together. So sometimes if you get used to one tool of assessing delirium or the other tool, maybe work with the team and look at your patient population. Maybe something else is out there that we can use that's validated tool. Like we chose to have a ICD-CS for our patient population. Definitely get the buy-in from the hospital administration. So have any meetings that you have, invite them to your meetings, invite them so they can see why you need this equipment. Why do you need that equipment, for example? What's impact, like length of stay? It goes to the financial, so we can talk to operational leaders onto the impact of use these tools on your patient population. That's why you need that equipment or whatnot. Definitely open up the conversation about telemedicine in your institutions. Talk about preventative care. What if my post-surgical patients, maybe follow-ups can be virtual follow-ups in the first week. Don't wait till like 2-3 weeks when the patient can get an appointment. Maybe we can do it earlier. And if patient has a diabetes and he has a little bit like of wound going on, so maybe we need to follow up with them early, and virtually we can assess and we make a decision what is there. We can also help, like Dr. Eli is talking about, like, preventative of delirium. They are coming out of ICU, they still have a little bit of forgetfulness that maybe in our visits with the patients, we can ask them about quality of life, quality of sleep, what tools we can use, and kind of like help them to battle the delirium and assess your continuous coming barriers. As a teaching institution, we have residents come and go, but we don't know if they're coming from the place where battling delirium. Are they evidence-based? Are they there following the research and what we're doing? So there is a barrier, but maybe we can put something in place, like maybe mandatory education for the nurses. So, nurses already there. Nurse is not going anywhere. So we have it as a standard. So residents come in, the nurse just saying, hey, this is what we do. This is what preventing a delirium for a patient is important. So kind of like working together on that one. Next slide. And putting it together on the wheel, because as I talked, delirium is preventable. What we implemented, and here right now in the Kaiser LMC, what we're doing a journal club, having announcements right there. So in November 2nd, Thursday of the month, we're meeting together and we're discussing what we're going to do. We already have our physicians will be speaking on delirium as well to our nurses. And that is something that we're implementing in the policy regionally here at Kaiser LMC. We have data delirium policy that's going to be an entire region of Southern California. And region is hospitals, not only Southern California, but also Hawaii. Hawaii also goes into our region. So something we're battling together. And policy procedures are there for all. So we make sure the assessment of delirium are there and preventative measures are in place of the administration. So it's really helping us. And the next slide. Let's see. I would like to have us say the words of gratitude to you, but also to my leaders at Cedars-Sinai Medical Center, Dr. Lay, my Kathleen Breda, who is, she's the director right now of a geriatrics care and for orthopedic department for all the programs, and she's leading delirium battlefield right there. So we're working there. And together here, I work with my leaders, I work with Myrna Diaz. She's director of critical care, professional education, and my critical care nurse educators. So we're kind of like composting and putting all together and working to battle delirium for all patient populations. And open for questions. Thank you so much for having me.
Thank you so much, Mrs. Svetlov. That was such a eye-opening and inspiring presentation, really allowing us to see from different perspectives that we otherwise wouldn't be able to understand. To the audience, don't forget to fill out the session evaluation survey to obtain your CME ethics credits. You can access the survey by scanning the QR code on the screen, and a link to complete today's session evaluation will be emailed to all the participants as well. We will now open the floor for questions and discussion.
So Dr. Neil and Dr. Lee, let's start the question and answer portion. You're muted, Dr. Neil.
Give me a second, Dr. Santos. This is being recorded. I want to make sure that I say the correct thing at the correct time. So I practice before I unmute. That was a fantastic presentation, very, very inspiring, and something that we all struggle to deal with no matter how good we try to do it. I guess my number one question for you is, obviously you have it appears to have a fairly large center. How many hospitals are you using that center on, and how many staff members do you have at a time in your facility screening patients?
Yeah, thank you so much. This is a very, very good question. So at the time we did the project, so on a daily basis, the census is 24 bed, right? So we were constantly doing it. So throughout the year at Cedars-Sinai, it's hundreds and hundreds of patients go through us. We have elective surgeries, we have transplants going in. So it's just 100 patients of screening pretty much on the basis. Here at Kaiser LMC, we're screening the patients. We have, let me just caught me off guard. I should have, I'm learning it. So I have 36. So we have 4 ICUs here of a 36 bed capacity. They're screening patient using the CAM ICU, and I already see that it's not really working at times with the patient population. So I asked my team to call me when the patient is really positive for delirium. So for the ICUs, I'm monitoring myself patients, and I'm assessing them myself and giving feedback to the team what things needs to be done. I'm also following up with the charge nurses and ensuring that the clustering care is happening during the night, promoting the sleep. And one of the aspects that we have to screen for this large patient populations, it's predominantly the bowel regimen protocol is not being implemented. So we have to remind the team, don't forget about gut. It's very important. And I'm in the works on that. But in Cedars-Sinai, it's for a 24-bed that unit. And it was just, gosh, hundreds of patients.
Thank you very much. Follow-up question. So you obviously you're screening those patients. Are you doing that continuously?
Yeah.
Via the telemedicine?
Yeah.
So is it like 1 or 2 people or 4 or 5 patients per person in that room? Because obviously you screen them and then things change. And so how do they notify you to then do to follow up the screening, if that makes sense? If it's not initially delirium, but then it has become delirium.
Yeah, so I do have access. We have a secure chat messaging. If something needs to be changed, and I need to come back and assess it. So through secure chat through Epic, I can go ahead and assess this patient. I also receive the census report of the patient that I need to follow up. So I see it in Epic, and also the charge nurse is notifying me. And then for nurses, it's mandatory to do a day shift and night shift. And if any change, they have it as well. Because obviously, like you said, they could be obviously fine during daytime, and it can be obviously absolutely different during the nighttime. So then I need to go back in the chart and look what needs to be done, what is assessing, what agents needs to be adjusted. And at 11 o'clock in ICU rounds, where multidisciplinary rounds happening, so we participate and we discuss what can we do better for this patient.
Perfect. Dr. Lee, Dr. Santos, do you have any questions?
The other thing, though, I noticed, follow-up question from Dr. Mills' question is the use of AI. With the continuous monitoring of CAM ICU, you could actually measure, or the Epic or Cerner, whatever you could potentially alarm you on your patient potentially developing delirium. Have you had any experience about using AI or artificial intelligence on alarming you which patient may potentially develop delirium in the future?
This is a very good question. So I'm being honest with you. So I left Cedars-Sinai in May of this year, and right now, because I got a nice offer at Kaiser LMC, so I can grow. And right before I left, there's Cedars-Sinai has accelerator where they're inviting innovators to come up with some kind of tool like tracking or alerting the providers about patients getting into delirium. So there are 2 things being discussed at that time. So there is a device that actually tracks your eye movements and actually predict if you're going to be in delirium, or you're about to be in a state of delirium. And there's another study that our neuro ICU are going to be really big, and at Cedars-Sinai discussing it. They're working with the AI and a program through the Epic to notify physicians, something like an analysis of the assessment that's been going on. And also they're doing the research with the patients on delirium. So it's something that's going to be coming out big. So I know there's like 2 things happening.
This is actually a very exciting event, Soya, that now we could use AI, to predict sepsis and to predict delirium. That's fantastic.
Yeah, the area of AI, it's a controversial talk. I don't know if you ever tried AI, chat GPT or any of that nature. It is an eye-opening, and we definitely can use it for our benefits and benefits of our patients. We just need to make sure we have regulations in place. But yeah, it is something we're excited. Mhm.
Yeah, I'm actually glad we have nurses speaking here because I think this could be a leverage to decrease burnout among our nurses doing a lot of things. This could make things job easier for our nurses, especially in the floor. They're taking care of 6 or more patients, and in the ICU, 2 is actually a lot, but sometimes they're taking care of 2 or 3 patients.
Yeah, absolutely, absolutely. Burnout. This is something that what we talk a lot recently with the American Association of Caregiver Nurses, with the ACN. We do have webinars, nurse well-being is a big component. 2020 really turned away a lot of nurses from the field, and nurses were affected mentally a lot. And so what we implemented here at Kaiser just right now, so anything that we do with the patients, let's say it's like intervention, so rapid response was going in, we ask people to debrief. We ask people to have a conversation, what can we do better? But we're also asking our ethics department to go ahead and follow up with providers and follow up with nurses. Have a closure, and then having the AI as a tool, kind of like helping us to look at the case scenario and kind of like realize, okay, what else could have been done? And we discuss and have it like more opportunities for discussion. But also as a provider, after Code Blue, how you are affected. You need to see the other patients, but your patients probably didn't have a good outcome. And you're a surgeon, you need to go back to the surgery. How can you maintain your well-being? So definitely for the burnout is a big deal. We're implementing this in the policy in Code Blue here. It's like, okay, have a closure, have a debrief, make sure it's this and this, and it's all spelled out. So it's in a basis for all of us. And I hope we can help us together come in and help us together to care for patients and making sure we're in a good state of mind to continue our care.
Absolutely. That is a great talk. Any questions, Dr. Lee, Dr. Neil, Zoya? Anyone from the audience?
How
You
often
could
do
just-
you ask psychiatrists or psychologists to help with the staff, I guess, burnout or stress from dealing with, patients who's delirious?
Psychologist, we have 2 CNSs. So at the time of the project we were implementing, the institution decided to implement, they actually created a position for a clinical nurse specialist who was really dealing with the high acuity patients, and it will round on them. In terms of well-being, we did not have psychiatrists or psychologists talking to us. I think it's a great idea. Thank you for bringing it up. I think we can open up. Yeah, I never thought about it. Yeah, that will be very good support. They are professionals. They are experts. They know the best how to get these tools to us. I think this is something that we definitely need to ask for, and that will definitely help us. It's a great question. Thank you.
Any other question from the audience?
Hi, this is Sharon Wilson. Great talk, Olena. Can you hear me?
Yes. Thank
Okay.
you.
I have a question for you. When you guys did the study looking at the 2 different ICU delirium scores, and you found that the CAM ICU wasn't as great for trauma patients, did you see that in any other patient population?
Yeah, it was not good for liver transplant population. It wasn't good for kidney transplant population because they were in immunosuppressants.
Okay,
and
yes.
A lot of tutoring was going on. So as a nurse compliance, nurses were documenting it. It's like, okay, Olena, just don't follow me up. I just did it. Don't come to me. And it was like, that is strong barrier. So I recall at night, I stayed late and I walked with my night nurse all the way to the parking lot. I'm like, hey, can you just tell me what can we do? I was like, Olena, it doesn't work. I'll just document it. But I'm telling you, honestly, it doesn't work for the patient. I'm just documented so nobody will come for administration telling me that I did not do the chart. So I was like, wow, well, why didn't you tell me earlier? So I guess, when I'm on the unit, I'm in scrubs. Like I don't wear any of the pearls or anything. It's just for us today. And I know it's recorded. I'm in scrubs. I am with them, so they don't see me a little bit different. And I see doctors are also in scrubs and are working with us in scrubs. So it kind of like alleviate that barrier where nurses can actually tell me, Olena, what is working, what is not. And then this is what pushes us to search what is out there. This is where residents were really digging in and trying to see what is out there. We even developed like a map, just like, residents amazing. It's like so cool to work with them. Yeah. So
Yes,
that's
okay.
how we discovered that tool.
All right, thank you.
All right. Well, that is fantastic talk where we went beyond time, but that's okay. Thank you very much, Olena, Jakuyu. Thank you very much for this fantastic presentation and everyone who joined us today. By the way, there are references there in your chat box. That is courtesy by our medical librarian, Dr. Daniel Stewart, who provided citations in the chat to our wonderful team that makes this series possible. Max and Laura, thank you very much. We would like to present to you, Olena, this challenge coin. We're going to mail it to you for this wonderful seminar, courtesy of TexLa. And thank you for your contributions to the scientific community and for the positive impact you had on your patients, and continue the wonderful work you've been doing.
Thank you
By the
so
way,
much.
just a quick, thank you very much. So you will receive the challenge coin in your mail. All right. And also next presentation will be on November 10th. We will be talking with our Texas Tech alumni, Dr. Rania Habash, about teleophthalmology, the great telehealth playbook. She is an ophthalmology from Florida, and we will be seeing you hopefully, to register in our website and join us for our next telemedicine session. Olena, Dr. Svetlov, thank you very much again.